Diagnosis and Management of Ectopic Pregnancy. Green Top Guideline Number 21, Royal College of Obstetricians and Gynecologists, Association of Early Pregnancy Units Joint Guideline, November 2016. Introduction and Background to Epidemiology. An ectopic pregnancy is any pregnancy implanted outside of the endometrial cavity. In the UK, the incidence is approximately 11 over 1,000 pregnancies. The incidence of ectopic pregnancy in women attending early pregnancy units is 2 to 3%. Unfortunately, women still die from ectopic pregnancy, with 6 maternal deaths reported between 2006 and 2008. Risk factors for ectopic pregnancy include tubal damage following surgery or infection, smoking, and in vitro fertilization. However, the majority of women with an ectopic pregnancy have no identifiable risk factor. Diagnosis of ectopic pregnancy. How is a tubal pregnancy diagnosed? What are the ultrasound criteria? Transvaginal ultrasound is a diagnostic tool of choice for tubal ectopic pregnancy. Tubal ectopic pregnancy should be positively identified, if possible, by visualizing an adnexal mass that moves separate to the ovary. Transvaginal ultrasound has reported sensitivities of 87.0 to 99.0% and specificities of 94.0 to 99.9% for the diagnosis of ectopic pregnancy. The majority of ectopic pregnancies will be visualized on the initial ultrasound examination. The remainder will initially be classified as a PUL or pregnancy of unknown location. Not all ectopic pregnancies initially classified as a PUL are missed on the initial scan. Some of these ectopic pregnancies are just too small and too early in the disease process to be visualized on the initial ultrasound examination. Laparoscopy is no longer the gold standard for diagnosis. False negative laparoscopies, 3.0 to 4.5%, have been reported when the procedure is performed too early in the development of an ongoing ectopic pregnancy. An inhomogeneous or non-cystic adnexal mass is the most common finding in around 50 to 60% of cases. An empty extrauterine gestational sac will be present in around 20 to 40% of cases. While an extrauterine gestational sac containing a yolk sac and/or embryonic pole that may or may not have cardiac activity will be present in around 15 to 20% of cases. There is no specific endometrial appearance or thickness to support a diagnosis of tubal ectopic pregnancy. In up to 20% of cases, a collection of fluid may be seen within the uterine cavity, classically referred to as pseudosac. The intradecidual and double decidual signs can be used to diagnose an early intrauterine pregnancy. The intradecidual sign is described as a fluid collection with an echogenic rim located within a markedly thickened decidua on one side of the uterine cavity. The double decidual sign is described as an intrauterine fluid collection surrounded by two concentric echogenic rings. In practice, it can be very difficult to distinguish a pseudosac, which is just a collection of fluid, in the endometrial cavity from an early intrauterine sac. The presence of a pseudosac alone cannot be used to diagnose an ectopic pregnancy, and in fact, a small anechoic cystic structure is more likely to be an early sac rather than a pseudosac. Free fluid is often seen on ultrasound but is not diagnostic of ectopic pregnancy. A small amount of anechoic fluid in the pouch of Douglas may be found in both intrauterine and ectopic pregnancies. Echogenic fluid has been reported in 28 to 56% of ectopic pregnancies. It may signify tubal rupture, but most commonly is due to blood leaking from the fimbrial end of the fallopian tube. What biochemical investigations should be carried out? A serum progesterone level is not useful in predicting ectopic pregnancy. A serum beta-human chorionic gonadotrophin level is useful for planning the management of an ultrasound visualized ectopic pregnancy. A meta-analysis has confirmed that a single beta-human chorionic gonadotrophin level cannot be used in isolation to predict an ectopic pregnancy. The initial serum beta-HCG level is a key prognostic indicator for the success of conservative management, expectant and medical, in cases of ultrasound visualized tubal ectopic pregnancies. How is a cervical pregnancy diagnosed? What are the ultrasound criteria? The following ultrasound criteria may be used for the diagnosis of cervical ectopic pregnancy: an empty uterus, a barrel-shaped cervix, a gestational sac present below the level of the internal cervical os, the absence of the sliding sign, and blood flow around the gestational sac using color Doppler. Cervical pregnancies are rare, accounting for less than 1% of all ectopic gestations. The sliding sign enables cervical ectopic pregnancies to be distinguished from miscarriages that are within the cervical canal. When pressure is applied to the cervix using the probe in a miscarriage, the gestational sac slides against the endocervical canal, but it does not in an implanted cervical pregnancy. What biochemical investigations should be carried out? A single serum beta-human chorionic gonadotrophin should be carried out at diagnosis. A single serum beta-HCG carried out at the time of ultrasound diagnosis is useful in deciding management options. A serum beta-HCG level greater than 10,000 international units per liter is associated with a decreased chance of successful methotrexate treatment. How is a cesarean scar pregnancy diagnosed? What are the ultrasound criteria? Clinicians should be aware that ultrasound is the primary diagnostic modality using a transvaginal approach supplemented by transabdominal imaging if required. Defined criteria for diagnosing cesarean scar pregnancy on transvaginal scan have been described. Magnetic resonance imaging or MRI can be used as a second-line investigation if the diagnosis is equivocal and there is local expertise in the MRI diagnosis of cesarean scar pregnancies. Cesarean scar pregnancy is defined as implantation into the myometrial defect occurring at the site of the previous uterine incision. The prevalence of cesarean scar pregnancy is estimated to be approximately 1 in 2,000 pregnancies, and these pregnancies may be ongoing potentially viable pregnancies or miscarriages within the scar. The diagnostic criteria described for diagnosing cesarean scar implantation on transvaginal ultrasound include empty uterine cavity, gestational sac or solid mass of trophoblast located anteriorly at the level of the internal os, embedded at the site of the previous lower uterine segment cesarean section scar, thin or absent layer of myometrium between the gestational sac and the bladder, evidence of prominent trophoblastic and/or placental circulation on Doppler examination, and empty endocervical canal. %13 of reported cases of cesarean scar pregnancy were misdiagnosed as intrauterine or cervical pregnancies at presentation. The true prevalence of cesarean scar pregnancies is likely to be somewhat higher than estimated in the literature, as some cases will end in the first trimester, either by miscarriage or termination, and go unreported and undiagnosed. There is a spectrum of severity associated with pregnancies implanted into cesarean section scars, and the natural history is uncertain. Veal et al. Proposed that there are two different types of pregnancies implanted in a cesarean scar. The first type, progressing into the uterine cavity, as the gestational sac grows and develops, so with the potential to reach a viable gestational age, but with the risk of massive bleeding from the implantation site, and the second, with progression deeper towards the serosal surface of the uterus, with the risk of first trimester rupture and hemorrhage. Given that there are also varying appearances of cesarean section scars on the uterus, and that placental development evolves over time as the pregnancy progresses, all of these factors can cause difficulty in the diagnosis of cesarean scar pregnancy. The diagnostic criteria have not been subject to validation and are derived from descriptive case series, so to minimize the risk of false positive diagnosis, we recommend that all non-emergency cases of suspected scar pregnancy are referred to a regional center to confirm the diagnosis. The MRI features of cesarean scar pregnancy are essentially the same as those described on ultrasound. What biochemical investigations should be carried out? No biochemical investigations are needed routinely. A serum beta-HCG level may be useful as a baseline prior to monitoring if conservative treatment is contemplated, but it does not have a role in the diagnosis of cesarean scar pregnancy. How is an interstitial pregnancy diagnosed? What are the ultrasound criteria? The following ultrasound scan criteria may be used for the diagnosis of interstitial pregnancy: empty uterine cavity, products of conception and/or gestational sac located laterally in the interstitial or intramural part of the tube and surrounded by less than 5 mm of myometrium in all imaging planes, and presence of the interstitial line sign. Sonographic findings in 2-dimension can be further confirmed using 3-dimensional ultrasound where available to avoid misdiagnosis with early intrauterine or angular implantation in the lateral angles of the uterine cavity pregnancy. Supplementation with MRI can also be helpful in the diagnosis of interstitial pregnancy. Interstitial pregnancy occurs when the ectopic pregnancy implants in the interstitial part of the fallopian tube. The reported incidence varies between 1.0% and 6.3% of ectopic pregnancies. The interstitial part of the fallopian tube is about 1 to 2 cm in length and traverses the muscular myometrium of the uterine wall, opening via the tubal ostium into the uterine cavity. The interstitial line sign is a thin echogenic line extending from the central uterine cavity echo to the periphery of the interstitial sac. The interstitial line sign has been shown to have a sensitivity of 80% and a specificity of 98% for the diagnosis of interstitial ectopic pregnancy. What biochemical investigations should be carried out? A single serum beta-HCG should be carried out at diagnosis to help with management. In some cases, a repeat serum beta-HCG in 48 hours may be useful in deciding further management. At presentation, based on clinical symptoms and ultrasound scan, if there is suspicion of interstitial pregnancy, a single serum beta-HCG should be carried out. This does not contribute to the diagnosis but can be useful in deciding management options such as surgical, medical, or expectant treatment. The overall decision regarding management options depends upon clinical presentation, size of the interstitial pregnancy, presence of fetal cardiac activity, and the serum beta-HCG level. In some cases, with a small interstitial pregnancy identified on an ultrasound scan, a repeat serum beta-HCG in 48 hours may be helpful in deciding management options. How is a Cornual pregnancy diagnosed? What are the ultrasound criteria? The following ultrasound scan criteria may be used for the diagnosis of Cornual pregnancy: visualization of a single interstitial portion of fallopian tube in the main uterine body, gestational sac and/or products of conception seen mobile and separate from the uterus and completely surrounded by myometrium, and a vascular pedicle adjoining the gestational sac to the unicornuate uterus. Cornual pregnancy is defined as implantation in a congenitally abnormal uterus. Cornual pregnancy is the rarest form of ectopic pregnancy, with a reported incidence of 1 in 76,000 pregnancies. What biochemical investigations should be carried out? A single serum beta-HCG should be carried out at diagnosis to help with management. In some cases, a repeat serum beta-HCG in 48 hours may be useful in deciding further management. How is an ovarian pregnancy diagnosed? What are the ultrasound criteria? There are no specific agreed criteria for the ultrasound diagnosis of ovarian ectopic pregnancy. Findings suggestive of an ovarian ectopic pregnancy on transvaginal ultrasound with an empty uterus are a wide echogenic ring with an internal anechoic area on the ovary. It is not possible to separate the cystic structure or gestational sac from the ovary on gentle palpation or the negative sliding organ sign. The corpus luteum should be identified separate from the suspected ovarian pregnancy. Color Doppler may aid detection of a fetal heart pulsation within the ovary. As it can be difficult to distinguish ovarian ectopic pregnancies from corpus luteal cysts, tubal ectopic pregnancy stuck to the ovary, a second corpus luteum, ovarian germ cell tumors, and other ovarian pathologies, diagnosis is usually confirmed surgically and histologically. What biochemical investigations should be carried out? A single serum beta-HCG should be carried out at diagnosis to help with management. In some cases, a repeat serum beta-HCG in 48 hours may be useful in deciding further management. Ovarian ectopic pregnancy can be difficult to diagnose with certainty preoperatively, so the diagnosis should be considered whenever ultrasound findings are suspicious. After surgical treatment, the histopathology result will confirm the diagnosis of ovarian ectopic pregnancy. How is abdominal pregnancy diagnosed? What are the ultrasound criteria? Defined ultrasound criteria can be used to diagnose an abdominal pregnancy. MRI can be a useful diagnostic adjunct in advanced abdominal pregnancy and can help to plan the surgical approach. The following ultrasound criteria have been suggested as being diagnostic of an early abdominal pregnancy: absence of an intrauterine gestational sac, absence of both an evident dilated tube and a complex adnexal mass, a gestational cavity surrounded by loops of bowel and separated from them by peritoneum, a wide mobility similar to fluctuation of the sac, particularly evident with pressure of the transvaginal probe toward the posterior cul-de-sac. In a clinically stable patient where abdominal pregnancy is identified, or strongly suspected on ultrasound, MRI can help to confirm the diagnosis and to identify placental implantation over vital structures such as major blood vessels or bowel. These can help to guide perioperative considerations such as the surgical team, blood products, preoperative angiographic embolization, bowel preparation, and insertion of ureteral catheters. Ultrasound and/or MRI can be used to precisely map the location of the placenta prior to laparotomy so as to avoid incising the placenta and the associated risk of uncontrollable hemorrhage. What biochemical investigations should be carried out? A high index of suspicion is based upon an elevated serum beta-HCG level in combination with ultrasound findings. An early abdominal pregnancy is usually diagnosed at laparoscopy during investigation for a persistently elevated serum beta-HCG level. How is heterotopic pregnancy diagnosed? What are the ultrasound criteria? A heterotopic pregnancy is diagnosed when the ultrasound findings demonstrate an intrauterine pregnancy and a coexisting ectopic pregnancy. Heterotopic pregnancy should be considered in all women presenting after assisted reproductive technologies, in women with an intrauterine pregnancy complaining of persistent pelvic pain, and in those women with a persistently raised beta-HCG level following miscarriage or termination of pregnancy. What biochemical investigations should be carried out? A serum beta-HCG level is of limited value in diagnosing heterotopic pregnancy. A higher than expected level of serum beta-HCG in relation to gestational age may be suspicious of heterotopic gestations, although the presence of a complete or partial mole must also be considered. Management options. What are the surgical, pharmacological, or conservative treatment options for tubal pregnancy? A laparoscopic surgical approach is preferable to an open approach. In the presence of a healthy contralateral tube, selfingectomy should be performed in preference to selfingotomy. In women with a history of fertility-reducing factors, such as previous ectopic pregnancy, contralateral tubal damage, previous abdominal surgery, previous pelvic inflammatory disease, selfingotomy should be considered. If a selfingotomy is performed, women should be informed about the risk of persistent trophoblast with the need for serum beta-HCG level follow-up. They should also be counseled that there is a small risk that they may need further treatment in the form of systemic methotrexate or selfingectomy. Systemic methotrexate may be offered to suitable women with a tubal ectopic pregnancy. It should never be given at the first visit unless the diagnosis of ectopic pregnancy is absolutely clear and a viable intrauterine pregnancy has been excluded. Expectant management is an option for clinically stable women with an ultrasound diagnosis of ectopic pregnancy and a decreasing beta HCG level, initially less than 1,500 international units per liter. Surgical management. Laparoscopy is preferable to laparotomy due to its many advantages, such as shorter operation time, less intraoperative blood loss, shorter hospital stay, lower cost, lower analgesic requirements, and less adhesion formation. Evidence, however, suggests that there is no difference in terms of health benefits between laparoscopy and laparotomy, including the key outcome of subsequent successful pregnancy. In women with a tubal ectopic pregnancy and a healthy contralateral tube, salpingotomy does not significantly improve fertility prospects compared with salpingectomy. Higher rates of subsequent intrauterine pregnancy have been found if salpingotomy is performed rather than salpingectomy in women with a history of fertility-reducing factors such as previous ectopic pregnancy, contralateral tubal damage, previous abdominal surgery, and previous pelvic inflammatory disease. One study found subsequent intrauterine pregnancy rates of 75% with salpingotomy and 40% with salpingectomy in such women. However, subsequent intrauterine pregnancy rates were greater than 90% in both groups in women without fertility-reducing factors. Persistent trophoblast is detected by the failure of serum beta HCG levels to fall as expected after initial treatment. It is primarily a problem occurring after salpingotomy rather than following salpingectomy. The National Institute for Health and Care Excellence recommends that women undergoing salpingotomy have a serum beta HCG level taken 7 days after surgery and then weekly until a negative result is obtained. Studies have reported persistent trophoblast rates of 3.9 to 11.0% after salpingotomy. Factors that have been suggested as increasing the risk of developing persistent trophoblast include higher preoperative serum beta HCG levels, a rapid preoperative rise in serum beta HCG, and larger tubal masses. Pharmacological management. Methotrexate at a dose of 50 mg per cubic meter has been widely used as a single dose instead of a repeat surgical procedure. The use of prophylactic methotrexate at the time of laparoscopic salpingotomy has also been reported, and when compared with simple salpingotomy alone, there was a significant reduction in the rate of persistent trophoblast. Systemic methotrexate is the most commonly used drug for the pharmacological treatment of tubal ectopic pregnancy. While it can be given in a multiple dose regimen, methotrexate is most commonly given as a single intramuscular dose of 50 mg per cubic meter. Serum beta HCG levels are measured on days 4 and 7 post methotrexate. If the beta HCG level decreases by more than 15% between days 4 and 7, beta HCG levels are then measured weekly until less than 15 international units per liter. If the level does not decrease by 15%, a repeat transvaginal ultrasound should be considered to exclude ectopic fetal cardiac activity and the presence of significant hemoperitoneum. Consideration may then be given to administration of a second dose of methotrexate. Overall, success rates of single-dose methotrexate for tubal ectopic pregnancy range from 65 to 95%, with 3 to 27% of women requiring a second dose. Success rates vary considerably due to different inclusion criteria. There are a number of predictors of success. Initial serum beta-HCG level. Success rates of 81 to 98% have been reported if serum beta-HCG levels are less than 1,000 international unit per liter, compared with only 38% if beta-HCG levels are greater than 5,000 international units per liter. Ultrasound appearance of the ectopic pregnancy. The presence of a yolk sac, fetal pole, and/or fetal cardiac activity are significant predictors of failure. Success rates are higher when no gestational sac is visualized. Pre-treatment changes in serum beta-HCG levels. The smaller the increase in beta-HCG level prior to administration of methotrexate, the higher the chance of successful medical management. A beta-HCG increase of up to 11 to 20% over 48 hours prior to the administration of methotrexate has been associated with higher rates of success. Decrease in beta-HCG levels from day 1 to day 4 after methotrexate. Success rates of 88 to 100% have been reported if the serum beta-HCG level decreases from day 1 to day 4 post-administration of methotrexate, compared with only 42 to 62% if the serum beta-HCG level increases. During treatment with methotrexate, women should be advised to avoid alcohol and folate-containing vitamins. There are adverse effects, which include marrow suppression, pulmonary fibrosis, nonspecific pneumonitis, liver cirrhosis, renal failure, and gastric ulceration. The most common adverse effects are excessive flatulence and bloating due to intestinal gas formation, a transient mild elevation in liver enzymes, and stomatitis. The National Institute for Health and Care Excellence recommends that methotrexate should be the first-line management for women who are able to return for follow-up and who have no significant pain, an unruptured ectopic pregnancy with a mass smaller than 35 millimeters with no visible heartbeat, a serum beta-HCG between 1,500 and 5,000 international units per liter, and no intrauterine pregnancy as confirmed on ultrasound scan. However, before administering methotrexate, it is essential that the diagnosis of ectopic pregnancy is correct. As the majority of ectopic pregnancies are visualized as inhomogeneous masses, it is prudent to repeat the serum beta-HCG in such cases in 48 hours. In the event of the serum beta-HCG dropping, then expectant management may be appropriate. Should the serum beta-HCG be rising at a rate that may be consistent with a viable intrauterine pregnancy, then a repeat scan to check the diagnosis before administering methotrexate is advisable. Expectant management. Expectant management is a reasonable option for appropriately selected and counseled women. They must be willing and able to attend for follow-up, have minimal pain, and have low or declining serum beta-HCG levels. Success rates range from 57 to 100% and are very dependent on case selection. Success rates are inversely proportional to serum beta-HCG levels, with lower success rates associated with higher initial serum beta-HCG levels. Selection criteria for expectant management are clinical stability with no abdominal pain, no evidence of significant hemoperitoneum on ultrasound scan, an ectopic pregnancy measuring less than 30 millimeters in mean diameter with no evidence of embryonic cardiac activity, a serum beta-HCG level of less than 1,500 international units per liter, and the woman's consent. A decreasing serum beta-HCG level is also a good predictor of success. One question that is often raised is whether there is a benefit in giving methotrexate rather than managing expectantly. A multi-center RCT was performed to assess the treatment success rate of systemic methotrexate compared with expectant management in women with an ectopic pregnancy or a PUL with low or plateauing serum beta-HCG levels, less than 1,500 international units per liter, and less than 2,000 international units per liter for ectopic pregnancy and PUL, respectively. They found that there was no difference in the primary treatment success rate of single-dose methotrexate versus expectant management. What are the surgical, pharmacological, or conservative treatment options for cervical pregnancy? Medical management with methotrexate can be considered for cervical pregnancy. Surgical methods of management are associated with a high failure rate and should be reserved for those women suffering life-threatening bleeding. Early, accurate diagnosis is the key factor in the conservative management of cervical pregnancies. Gestational age less than 12 plus 0 weeks, absence of fetal cardiac activity, and lower serum beta-HCG levels are associated with more successful conservative management. In a retrospective study, gestational age more than 9 plus 0 weeks, beta-HCG levels greater than 10,000 international units per liter, crown ramp length greater than 10 millimeters, and fetal cardiac activity were shown to be associated with a higher risk of primary failure of the treatment of cervical ectopic pregnancy with systemic methotrexate. In addition, combination therapy with intraamniotic injection seemed to increase the chance of successful treatment in this retrospective study. A number of adjunctive methods to control hemorrhage in the treatment of cervical ectopic pregnancy have been described, These include uterine artery ligation and uterine artery embolization. Case series report success with these methods in combination with intracervical or systemic methotrexate, but the number of cases reported are small and associated complications include infection, uterine infarction, sciatic nerve injury, and necrosis of the bladder or rectum. Traditionally, cervical ectopic pregnancies were managed with dilatation and curettage with additional measures designed to reduce the amount of hemorrhage. However, rates of excessive bleeding necessitating hysterectomy were high, and therefore its use should be restricted to those women for whom alternative measures are unsuitable. What are the surgical, pharmacological, or conservative treatment options for cesarean scar pregnancy? Women diagnosed with cesarean section scar pregnancies should be counseled that such pregnancies are associated with severe maternal morbidity and mortality. Medical and surgical interventions, with or without additional hemostatic measures, should be considered in women with first trimester cesarean scar pregnancy. There is insufficient evidence to recommend any one specific intervention over another for cesarean scar pregnancy, but the current literature supports a surgical rather than medical approach as the most effective. Primary medical treatment consists of using methotrexate, which may be administered by local injection into the gestational sac under ultrasound guidance or systematically by intramuscular injection. Local injection seems to be a more effective means of terminating the pregnancy. The disadvantage of using medical treatment is that the trophoblast remains in situ. There is a risk of hemorrhage as the retained, often very vascular, placental tissues degenerates, so some authors have advocated using suction evacuation in addition to methotrexate to hasten resolution and reduce the risk of unpredictable hemorrhage in the follow-up period. Surgical treatment consists of either evacuation of the pregnancy using suction or hysteroscopic resection, or excision of the pregnancy as an open laparoscopic or transvaginal procedure. Excisional techniques have the advantage of incorporating a repair of the scar, but these procedures are technically more difficult and invasive, and it is not known whether scar repair reduces the risk of recurrent cesarean scar pregnancy or scar rupture in future pregnancies. Expectant management may be suitable for women with small, non-viable scar pregnancies and may be considered if the pregnancy is partially implanted into the scar and grows into the uterine cavity, provided that the woman is counseled regarding the associated potential risks, hemorrhage, and morbidly adherent placentation, and she declines termination of the pregnancy. The management of ongoing second trimester scar pregnancies is challenging with the high risk of maternal morbidity and hysterectomy, whichever approach is taken. In these cases, the risk of surgical intervention must be balanced with the risk of allowing the pregnancy to continue with the aim of reaching a potentially viable gestational age. Women with such pregnancies should have a care package put in place for morbidly adherent placenta with a plan for emergency intervention should hemorrhage or rupture occur. What are the surgical, pharmacological, or conservative treatment options for interstitial pregnancy? Non-surgical management is an acceptable option for stable interstitial pregnancies. Expectant management is only suitable for women with low or significantly falling beta-HCG levels in whom the addition of methotrexate may not improve the outcome. A pharmacological approach using methotrexate has been shown to be effective, although there is insufficient evidence to recommend local or systemic approach. Surgical management by laparoscopic cornual resection or salpingotomy is an effective option. Alternative surgical techniques could include hysteroscopic resection under laparoscopic or ultrasound guidance. There is insufficient evidence on safety and complications in future pregnancies to recommend other non-surgical methods. The likely success of conservative management is determined by the initial level of serum beta-HCG. The options for conservative management include expectant management or a pharmacological approach using local or systemic methotrexate. Other described methods include transvaginal ultrasound guided aspiration of the exochylemic fluid from the gestational sac, followed by intrasaccular injection of 25 milligrams of methotrexate with or without zero point 0.2 to zero point 0.4 milliequivalent of potassium chloride. This is reported to have a 91% success rate with the advantages of fewer adverse effects and the ability to perform embryocide at the same time if required. The disadvantage is that it is a technically more challenging procedure. Embryocide has been shown to improve the success rate of the procedure. Other reported non-surgical techniques include selective uterine artery embolization used in conjunction with methotrexate to reduce hemorrhage. What are the surgical, pharmacological, or conservative treatment options for Cornual pregnancy? Cornual pregnancies should be managed by excision of the rudimentary horn via laparoscopy or laparotomy. Conservative, laparoscopic, and open surgical methods of management have all been described. However, to avoid recurrence, excision of the rudimentary horn seems to be the best approach. The laparoscopic technique is safe, but attention needs to be paid to the possibility of urinary tract anomalies, which can be associated with unicornuate uteri. The technique involves excision of the fibrous band that attaches the rudimentary horn to the unicornuate uterus, with removal of the rudimentary horn through the secondary port. What are the surgical, pharmacological, or conservative treatment options for ovarian pregnancy? Definitive surgical treatment is preferred if laparoscopy is required to make the diagnosis of ovarian ectopic pregnancy. Systemic methotrexate can be used to treat ovarian ectopic pregnancy when the risk of surgery is high or post-operatively in the presence of persistent residual trophoblast or persistently raised beta-HCG levels. Minimal access surgery is the treatment of choice for ovarian ectopic pregnancy. Removal of the gestational products by enucleation or wedge resection in the presence of a large ectopic mass is preferred. Enucleating the products of conception bluntly from the ovary minimizes damage to the surrounding ovarian tissue. Hemostasis can be achieved by electrocautery or suturing. Oophorectomy is occasionally required when there is coexisting ipsilateral ovarian pathology or excessive bleeding. There are no defined selection criteria or treatment or follow-up regimens of systemic methotrexate. What are the surgical, pharmacological, or conservative treatment options for abdominal pregnancy? Laparoscopic removal is an option for treatment of early abdominal pregnancy. Possible alternative treatment methods would be systemic methotrexate with ultrasound-guided fetocide. Advanced abdominal pregnancy should be managed by laparotomy. Laparoscopic treatment is a safe and effective option for the management of abdominal pregnancy when the diagnosis is made early and the site of implantation does not involve a vascular area. Laparoscopic management has been associated with reduced operative time, blood loss, and length of hospital stay when compared with laparotomy. Advanced abdominal pregnancy is associated with significant maternal and fetal morbidity and mortality, and once diagnosed, a laparotomy should be undertaken promptly. The surgical approach should be planned to avoid incision of the placenta. The placenta may be left in situ if the vascular attachment involves major vessels or vital structures and spontaneous resorption awaited. Preserving the placenta or its retention is associated with significant morbidity, ileus, bowel obstruction, fistula formation, hemorrhage, peritonitis, but the mortality is lower than with its removal. Adjuvant treatments with methotrexate and selective arterial embolization have been described. What are the surgical, pharmacological, or conservative treatment options for heterotopic pregnancy? The intrauterine pregnancy must be considered in the management plan. Methotrexate should only be considered if the intrauterine pregnancy is non-viable or if the woman does not wish to continue with the pregnancy. Local injection of potassium chloride or hyperosmolar glucose with aspiration of the sac contents is an option for clinically stable women. Surgical removal of the ectopic pregnancy is a method of choice for hemodynamically unstable women and is also an option for hemodynamically stable women. Expectant management is an option in heterotopic pregnancies where the ultrasound findings are of a non-viable pregnancy. Methotrexate is not an option for the treatment of women with a heterotopic pregnancy who have a viable intrauterine pregnancy or wish to continue with the pregnancy. Methotrexate, therefore, needs to be given only with very careful consideration as even local injection will affect the intrauterine pregnancy. In women with a viable pregnancy who do not wish to continue with the pregnancy, the Abortion Act regulations will apply. Medical management using local injection of hyperosmolar glucose into the extrauterine sac or potassium chloride into either the fetal pole, if possible, or the sac if not, alongside aspiration of the sac contents, minimizes the risk posed to the coexisting intrauterine pregnancy by surgical approaches. Ultrasound follow-up is necessary in these women to ensure resolution of the ectopic pregnancy as beta HCG levels cannot be used. This approach has been described for interstitial, Caesarean scar, and cervical heterotopic pregnancies. In those women presenting with heterotopic pregnancy who are hemodynamically unstable, surgical management should be carried out. In those hemodynamically stable women with an easily accessible ectopic pregnancy, such as a tubal, cervical, or interstitial heterotopic pregnancy, surgical removal is also an option. Care should be taken at the time of laparoscopy to avoid cannulation or manipulation of the uterus. Do Rhesus D or RHD negative women with an ectopic pregnancy require anti-D immunoglobulin? Offer anti-D prophylaxis as per national protocol to all RHD negative women who have surgical removal of an ectopic pregnancy or where bleeding is repeated, heavy, or associated with abdominal pain. Alloimmunization has been reported following ectopic pregnancy, and 25% of cases of ruptured tubal ectopic pregnancy are associated with a significant number of fetal cells in the maternal circulation. Women who undergo surgical management of ectopic pregnancy may be at higher risk of sensitization due to mixing of fetal and maternal blood. The risk of mixing of fetal and maternal blood following conservative or medical management is thought to be low. What are the long-term fertility prospects following an ectopic pregnancy? In the absence of a history or subfertility or tubal pathology, women should be advised that there is no difference in the rate of fertility, the risk of future tubal ectopic pregnancy, or tubal patency rates between the different management methods. Women with a previous history of subfertility should be advised that treatment of their tubal ectopic pregnancy with expectant or medical management is associated with improved reproductive outcomes compared with radical surgery. Women receiving methotrexate for the management of tubal ectopic pregnancy can be advised that there is no effect on ovarian reserve. Women undergoing treatment with uterine artery embolization and systemic methotrexate for non-tubal ectopic pregnancies can be advised that live births have been reported in subsequent pregnancies. Women undergoing laparoscopic management of ovarian pregnancies can be advised that their future fertility prospects are good. Several studies comparing surgical methods, medical and surgical management, and surgical and expectant management have confirmed that there are no statistical differences in the rate of recurrent ectopic pregnancy, with most long term follow up studies quoting a rate of around 18.5%. There is no difference in the tubal patency rates as examined by hysterosalpingography in women whose tubal ectopic pregnancies were managed expectantly or medically in the ipsilateral tube, or among those managed expectantly, medically, or surgically in the contralateral tube. In women with a history of subfertility, especially over the age of 35 years, radical surgery has been shown to be associated with lower rates of subsequent intrauterine pregnancy compared with conservative surgical or medical management. The future fertility outcomes of women undergoing laparoscopic surgery for ovarian ectopic pregnancy were examined in a small case series, which showed that 100% went on to conceive again, with 83% achieving a live birth. What support and counseling should be offered to women undergoing treatment for ectopic pregnancy? Women should be advised whenever possible of the advantages and disadvantages associated with each approach used for the treatment of ectopic pregnancy, and should participate fully in the selection of the most appropriate treatment. Women should be made aware of how to access support via patient support groups such as the Ectopic Pregnancy Trust or local bereavement counseling services. Muscle relaxation training may be of use to women undergoing treatment for ectopic pregnancy with methotrexate. It is recommended that women treated with methotrexate wait at least 3 months before trying to conceive again. The manufacturers of methotrexate recommend a 3-month window after use before conception due to the length of time that it may remain present in some organs and because of concern for subsequent pregnancy and fetal development. However, conception within 3 months of methotrexate should not be considered an indication for a termination. Service and training. What is the most appropriate setting for management of women with an ectopic pregnancy? Providers of early pregnancy care should provide a 7-day early pregnancy assessment service with direct access for women referred by general practitioners and accident and emergency departments, for example, along current NHS recommendations. Available facilities for the management of suspected ectopic pregnancy should include diagnostic and therapeutic algorithms, transvaginal ultrasound, and serum beta HCG estimations. Women should have access to all appropriate management options for their ectopic pregnancy. If local facilities do not provide all options, then clear referral pathways should exist to allow them to access appropriate care. What are the training implications for those managing women with ectopic pregnancy? Clinicians undertaking the surgical management of ectopic pregnancy must have received appropriate training. Laparoscopic surgery requires appropriate equipment and trained theater staff. Clinicians undertaking ultrasound for the diagnosis of ectopic pregnancy must have received appropriate training. Clinicians undertaking medical management via ultrasound-guided needle techniques must have received appropriate training. If clinicians undertaking surgical management of ectopic pregnancy cannot carry out the full range of surgical procedures, appropriately experienced support must be available if necessary. Virtual reality simulators can be used as a training tool for self-ingectomy. Appendix number 2. Single-dose protocol for intramuscular methotrexate. Appendix number 3. Contraindications to methotrexate: hemodynamic instability, presence of an intrauterine pregnancy, breastfeeding, if unable to comply with follow-up, known sensitivity to methotrexate, chronic liver disease, pre-existing blood dyscrasia, active pulmonary disease, immunodeficiency, and peptic ulcer disease.